very happy to announce that today's Patient Information Day is taking place with the support of the HSE National Lottery grant funding for 2021. This is ILFA's first time to receive National Lottery funding, and it's really going to help make a big difference to us this year. So we have a great line of speakers for you today, and I'd like to thank them for their expertise and their time in joining us this morning. And I hope you'll enjoy their presentations. So the order of speakers this morning is Professor Killian Hurley, followed by Dr. Anne-Marie Russell, who's joining us from the UK. Next, we have Dr. Kate Devenney. We'll take a short comfort break for 5 minutes at that stage, and we'll rejoin with Monica Devine, Professor John Baugh, and Sean O'Shea. You can submit any questions via the chat function on the bottom of the screen, and questions will be raised after each presentation. So our first speaker this morning is Professor Killian Hurley. Professor Hurley is an associate professor at RCSI and a consultant in respiratory medicine at Beaumont Hospital, where he also runs an interstitial lung disease service. He is a Health Research Board emerging clinical investigator studying familial pulmonary fibrosis and is the chair of the Irish Thoracic Society Interstitial Lung Disease Clinical Advisory Committee. Professor Hurley's presentation is entitled Better Care for Patients, Scheduled Care Pathways for Interstitial Lung Disease. I'd like to hand over to Professor Killian now. Thank you.
Great. Thanks so much, Nicola. And I'd like to thank ILFA for giving me the opportunity to speak today. And if I can just figure out how to share my screen.
So just down the bottom there, Killian, you should have a share screen button on the ribbon at the very bottom.
I see it, yeah. Thank you. Now,
perfect.
Great. So thanks so much. And I'm just going to speak over the next about 20 minutes, just about really the topic of scheduled care pathways for interstitial lung disease, and particularly in Ireland, where I think there's a real need for that. So first, I'm going to just explain what interstitial lung disease, talk through pulmonary fibrosis, because I know that a lot of people joining today may be joining the ILFA meeting for the first time. I'm going to talk about what a care pathway is and why we need them. I'm also going to outline what's been done so far in terms of care pathways in Ireland, what's best practice internationally, and what do we need in Ireland right now. So pulmonary fibrosis, often when I'm explaining to my patients, pulmonary fibrosis is scarring within the lungs, and it usually affects the very small parts of the lungs, the distant parts of the lungs where air is exchanged, and it causes scarring. Sometimes we can find a cause, and some of those causes might be medication side effects, radiation therapy to the chest, exposure to different types of molds or birds or fibers, autoimmune disease such as rheumatoid arthritis or scleroderma. But in most cases, no cause is found. And when that's the case, we call it IPF, or idiopathic pulmonary fibrosis. So patients or people who present with idiopathic pulmonary fibrosis have shortness of breath for up to 12 months before they present. They may have a dry cough, fatigue, weight loss. And what is when their doctor examines them, they can sometimes find this clubbing on their fingers, which is just a swelling of the nail. And when they listen to the back of their chest, they can hear this Velcro sounding sound from the back of their chest with the stethoscope. So what could cause idiopathic pulmonary fibrosis? So there's some theories around that it may be early aging of the lungs, the repair is not working normally, or the scarring is accelerated. But we do know that it affects the bottoms of the lungs, usually at first. And this causes, we often use this analogy of the bellows, that it causes stiffening of the lung bellows. So the lungs become stiff and difficult to take a breath. And that scarring causes damage to this area where oxygen is exchanged. And that can lead to the patient needing oxygen or not having enough oxygen. So the average age that someone is diagnosed with IPF is in their 60s and older. It's rare in those that are less than 50, slightly more common in men. We think that the annual incidence in Ireland is around 400 per year. So that's 8 per 100,000, but we think it's also increasing. So that would give a prevalence, or the number of patients that have IPF at any one time is about 1,000 patients in Ireland. Survival after diagnosis is a very wide range. People typically have one of three patterns: an accelerated pattern, a stepwise pattern where they have exacerbations or flare-ups of their IPF and it gets worse at each time, or a slow progression of their fibrosis. But as I say to my patients, you're not the average patient, and we don't know until we follow you for a while what your prognosis is. So it's difficult to give a number for everyone, and that's a very personal thing. So we make the diagnosis at a multidisciplinary meeting. So present at those kind of meetings are someone like myself, a respiratory physician, clinical nurse specialists, radiologists, thoracic surgeons, and pathologists. And of course, the patient is at the center of this meeting because we're discussing their case. Their case is presented. We may look at their x-rays, and if there's a biopsy available, if that's indicated, we'll look at their biopsy. A consensus is reached on the diagnosis, and then a plan is made to communicate that diagnosis with the patient, and also to communicate a management plan to the patient, and also if there further referrals are needed, or if even further investigations might be needed at that stage. So what are the treatments? So firstly, unfortunately, there's no cure for IPF as yet. We know that antacids can work for some patients because reflux or esophageal reflux can contribute to the disease. There are two new antifibrotic medications, pirfenidone and nintedanib, that can slow the progression. So this is a diagram. The blue is the patient, the pulmonary function test of the patient that's on treatment, and the red is the patient that's not on treatment. And you can see that the blue is decreasing less than the red. So what we call the FVC, or the forced vital capacity, reduces more slowly in a patient that's on treatment. Unfortunately, there can be side effects with these medications. Not everyone gets side effects, but some do. We haven't found a big study that shows there's an improvement in symptoms. While a study hasn't shown that there's a survival benefit, some of the registry data, so that's data from information from large collections of patients in different countries, show that there is a survival benefit on treatment with antifibrotics. And just to note that IPF alone doesn't respond to steroids or anti-inflammatories that we know of as yet. Of course, there are other treatments, non-medications. So the first and the key to treatment is information. So ILFA provides this, and this is a little picture of Nicola. She always likes when I show this one on top of Kirkpatrick. And ILFA provides information about treatments that are non-medications. So oxygen, pulmonary rehabilitation, and physiotherapy are all great treatments for pulmonary fibrosis. Exercise and monitoring we can do now remotely. Dietitian and social worker for some patients can help if they have need in terms of support in terms of their diet, or indeed with financial or psychosocial issues that they can be supported with. Palliative care is important for two issues: symptom control, and for some patients, end-of-life care. And transplant referral and assessment can be appropriate for some patients, although not for all. And this can be difficult to identify patients that are suitable for transplant. So what is a care pathway? So across the health sector, care pathway is often used interchangeably with other terms such as clinical pathway, clinical critical pathway, integrated care pathway, or care pathway journey. All the terms refer to a systematically planning or evaluating focused on patient care program. It's a framework, but care can be individual for patients with interstitial lung disease. And it's usually guided by principles, and also it needs to be delivered locally to patients. And it's based on national or international guidelines. So why do we need care pathways? Well, we know that there are benefits from being in an interstitial lung disease care referral center or a specialist center. So those that are referred earlier have a reduced mortality, and those that are referred over 4 years in this study have a worse prognosis if they're referred later. So this is one reason, but also patients feel more comfortable. They're more likely to get appropriate referrals and more likely to have their symptoms managed in a better way if they're in a specialist center. So what's been done so far in terms of care pathways? So ILFA has done a huge amount of work going back over 10 years ago now with the National Patient Charter for IPF. And this informs patients of 6 key areas that they're entitled to. That's an early and acute or accurate diagnosis, clear information about IPF, access to medications, oxygen, access to pulmonary rehabilitation, early referral to national lung transplant, and also support with access to psychological or palliative care services. In 2018, with the Irish Thoracic Society and ILFA, prepared a report for the Department of Health, which outlined what was needed in terms of care pathways, in terms of a national registry to document and record these patients that have IPF, and to outline what's needed in terms of care pathways and structures and multidisciplinary meetings across the country. So at that time, there were 7 specialists across the country in the bigger cities and referral centers in the bigger hospitals. And we had an Irish registry, and there was clinical trials ongoing. There's now 8 specialists across the country. However, there's no joined up framework to connect these and to connect them with the other hospitals across the country, and this is really needed. So the pathway that was outlined at the time was a care pathway. It outlined what should happen at each visit that the patient comes to the hospital or to a clinic, the MDT discussion, who should be at that, what kind of things should be discussed, a personal care plan devised, and the people that are involved in that care plan, including physios, OTs, dietitians, and other doctors, nurses, and paramedical staff. So 3 years on, how are we doing in terms of care pathways in Ireland? Well, ILFA tried to answer this question at the World Cafe Day and did a patient survey of 112 people that were online. And what they found was that 58% of patients reported they had access to clinical nurse specialists. Among those, 95 had contact over the phone with a clinical nurse specialist, and that may be due to the last year over COVID with the increase in virtual and phone clinics. And 92% of post-transplant patients, so that's patients that with IPF or ILD that had a transplant, they had access to a clinical nurse specialist. What services did they avail of? 38% only had been referred to physiotherapist or pulmonary rehab, 25% to a dietitian, and other services were really quite smaller amounts, less than 10% for social worker, occupational therapist, palliative care, clinical psychologist, and speech therapists. Really of note, 45% had not been referred to any service at that time. Also to note that people post-transplant had a better rate of referral onto specialists. So, as I said a little earlier, there is no HSE funded care program for ILD in Ireland at the moment that joins up the specialists with the support that patients need. So what is the best practice internationally? So it was a great report produced by the British Lung Foundation back in 2017, which outlined what was needed and is a good blueprint for what may be needed in Ireland. They outlined the key principles of care that should go into any care pathway. That's tailored interventions, that's medications that are specific to individual patients, collaboration, indication, and integration that's across doctors, nurses, and other paramedics, and across regions, equity of access. So not all areas within the UK were getting equal access to care for patients with IPF, and patient-centered communication and care. I think Anne-Marie Russ is going to speak about that afterwards, and also transparent data information. So that's checking in on how centers are doing and what their standards are like. So Owen judged who'd worked, Dr. Owen Judge, who'd worked in the UK, just helped me with what he outlined as the kind of care pathways that were in the UK. So that's the primary referral care. So that's usually a GP or an internal referrer from a non-specialist to secondary care. So that might be a hospital that doesn't have an ILD service. And that referral then will go to the center, to this tertiary or ILD center, which are regionally based. And then a performer-based referral is sent on to the MDT or the MDT meeting where the patients are discussed. Also, just from the report, the care pathway in the UK again shows this care pathway from the GP to secondary to the hospital onto a tertiary care specialist center. And at the bottom, then all those different types of paramedical care that's involved and other support services that are involved in taking care of patients that have complex lung disease. So what do we need in Ireland now? So I'm just going to outline really 4 points. First, we need to establish a task force for lung health and include interstitial lung disease in the Clontarf care program for scheduled care, as it isn't already. We need to create ILD networks across Ireland. So that's networks of hospitals and care services in the community that are connected together. We need to develop pathways, some of which I've just discussed, and publish these around these 5 principles of care. And we need to improve access to personalized treatments, diagnosis, and particularly supports, which seem to be lacking in Ireland. So my take-home messages from today are that pulmonary fibrosis is a progressive scarring lung disease, that the diagnosis is made and treatment delivered by a multidisciplinary team working together with the patient. Care pathways are frameworks for better care for individual people with ILD, and that the HSE and Department of Health, we need to work with these groups to ensure that ILD care pathways are included in the Clontarf care program of the future, and joining up our different specialists with the kind of supports that patients need. So thank you for your attention, and I'll be glad to take any questions. Thank you.
Thanks a million, Killian. Yeah, we have a couple of questions that's come in. I'm just going to stop and I'll just add myself as well to the spotlight there. I'm just going to invite in Eddie as well. Hopefully Eddie is he can hear us there. Okay, Eddie, are you okay? Just unmute there. There we go, Eddie. Hi, Eddie. And I'll just add Killian in as well there.
Right. Morning, Eddie.
Good morning, Killian. Sorry about the hiccup.
That's fine.
So yes, sorry, I have the questions here in front of me. Sorry, just too many windows open. First off, Killian, I'm sure this question gets asked a lot. Is it okay for patients to travel outside of Ireland at the moment?
That's a great question. I mean, I think that's an individual question for you and your doctor, or someone that takes care of you, because I think each patient has a slightly, and have quite different risk factors. I think people right now are concerned about getting COVID in other countries and getting sick in other countries. And I think that's a question that you may need to address to your doctor about your individual needs. Generally, I'm quite cautious with my patients in terms of traveling, and particularly at the moment, just because out of an abundance of cautions that they won't get sick abroad. But I think if someone is strong and healthy otherwise, and has been double vaccinated, I think it is safe. But again, if they're on other medications that may impair their immune system, that changes things. So my answer is it's an individual question, an individual response really for individual patients.
And so something that sort of ties in with that, could IPF patients be prioritized for booster vaccine? Can ILFA help encourage prioritization? Yeah,
that's a great question. I think patients with chronic and severe lung disease will be prioritized, and I think that's going to happen pretty soon, as they were on the first occasion. And again, that's something, linking in with your doctor, your GP, close to the time. But I think that I would imagine that will be announced in the coming weeks, that will happen. I know that they're now selecting patients that are on strong immunosuppression or have problems with their immune system, but I expect that they will start to vaccinate with boosters people with chronic lung disease, including IPF or pulmonary fibrosis.
Okay, we had one anonymous question in here. Are there
Sure.
genetic studies in progress where a number of patients from the same family are already diagnosed, and how can these be assessed by the family concerned?
Oh, yeah.
Difficult question, maybe.
Sure. No, that's a very good question. And in fact, we have a study in Beaumont Hospital and Royal College of Surgeons, which I lead, that looks at familial pulmonary fibrosis in Ireland. So if you would like to be included in that and you have one or more family members with pulmonary fibrosis, then if you talk to your GP and have them refer on to the pulmonary fibrosis service in Beaumont Hospital, we can assess you and see if we can include you in a study.
Someone just asked there in the chat box, is this being recorded? Yes, it is being recorded. So we will have this up in about 7 working days or so. What are the criteria for lung transplants? That's a
little difficult. I mean, I think the referrals usually when your pulmonary function tests and your symptoms. So really, first, this is kind of an individual thing, depending on why you're being transplanted, and when you're being referred on for transplant, it's always a balance of how severe is your lung disease, and also balancing that with when you have a lung transplant, it's not a perfect thing. It doesn't extend your life for a huge amount of time. It can extend your life 5 to 10 years. So it's always a balance of how sick the person is, what their breathing tests show, and how quickly their lung function is reducing, or their need for a transplant. And that's also balanced with if the patient also has other diseases that are ongoing at the same time, because lots of patients have other things that are going on, including heart disease or different types of disease that are going on at the same time. So it's a complex answer to a complex question, I think, but usually it's based on the pulmonary function tests decreasing and a patient having more symptoms.
Okay, I'm conscious of time. I know there's a load of questions coming in. We try and address some of these, and I'm going to promote some of the speakers here to an extra view that they can see some of the questions and they might be able to type them afterwards. Just a sort of a joint question here from Victor. Prescribed steroids, what are they doing? And can you explain why exercise is a good remedy?
Let me answer the second question first. Exercise is great for patients because when you have a severe lung disease, what can happen is you may exercise less because you're breathless, and that can lead to deconditioning of your muscles. And when you're deconditioned, then you're less fit, and that means you're less able to accommodate the problems that you have with your lungs. So being fit, being strong, and increasing the muscle supply to around your chest and your the breathing muscles can help you to breathe better, can help you manage your symptoms, and also I think can improve your quality of life. The steroids are not for everyone. There may be individual patients that do need steroids and benefit from them, but generally speaking, patients with IPF or idiopathic pulmonary fibrosis don't benefit from steroids, but those that have diseases secondary to connective tissue disease may benefit from steroids.
Okay, just that we're conscious of time and keeping running. I will hold up on some of the questions and we'll try and get some of them through the coffee break. And also I'll give you some controls there, Killian, in a moment there. You can see the questions coming in. I'm going to pass over to Eddie to announce the second speaker there. Thanks, Killian.
Thank you.
Thanks, Justin, and good morning, everybody. Sorry for the gremlins in the works, but we're back in action anyway. Our second speaker this morning is Dr. Anne-Marie Russell, a senior lecturer at the College of Medicine and Health at University of Exeter. She is a senior clinical fellow of the ILD services at the Royal Devon and Exeter and Imperial College Healthcare NHS Foundation Trust. Anne-Marie has expertise in patient-reported measures in interstitial lung disease. Anne-Marie is a great friend to ILFA, and we are delighted to extend a very warm Irish welcome to her this morning. The title of Anne-Marie's presentation is patient-centered consultations. So at this time, I will hand over to Anne-Marie. Thank you.
That's lovely. Thank you very much, Eddie. I'm just looking to share my screen.
Yep, it should be just down the bottom. You should have a little share icon. There's something written there. I can pull up your slides if need be, Anne-Marie.
Yeah, no, I think I'm okay. I think no gremlins my side.
It's just coming up now. That's it. Yeah, that's perfect.
Okay, is the view acceptable? Can you see?
So if you go to slideshow at the top of your screen there and just begin slideshow. Oh yeah, or that button there. Yep, that's perfect. That's it. Perfect.
So we just need to go back. Okay, we're good to go.
Yep.
Okay, lovely. Thank you. Yeah, so good morning, everyone. I have to say it's my absolute pleasure to be able to talk with you today, and I thank both Eddie and Nicola Cassidy for curating this session, and also to Gemma and Justin for their amazing organisation and administration support. Thank you. Working with ILFA is always an absolute delight. As my background, I've worked in interstitial lung disease research for about 14 years now, with always a key focus on patient-centeredness. And today we're going to talk about patient-centered consultations, which is perhaps already controversial as the spelling of patient-centeredness per se, differs by continent. And there's also a bit of an increasing trend to talk about person-centeredness, but for today's purposes, we'll stick with patient-centeredness. And so, reflecting on the origins of patient-centeredness, I guess this journey began as a descriptive account of how clinicians should interact and communicate with patients. And Enid Balint back in 1969 recognised the uniqueness of each individual patient. But despite recognising this uniqueness, there were some thoughts that throughout the 1960s, the consultations were littered with a degree of sentimentality. I would hope in the last 50 years that this has changed, but I suspect that it isn't always entirely the case, and we've still got a little bit of work to do. So in the late 70s, the patient-centered movement coincided with the introduction of what we call a biopsychosocial model of clinical care, which is probably quite easy to interpret. And this challenged a traditional biomedical approach that saw the doctor as expert and the patient as less so. And so the patient-centered movement has progressively recognised and incorporated the patient as expert in their care, but that doesn't come without a little bit of hard work. And I think that patients are very good and were perhaps in advance of this sort of official biopsychosocial model in recognising that whilst a condition might be experienced as biological in origin, the impact is felt physically, psychologically and socially. I think my slides are jumping a little bit here, but maybe that's a key to keep moving. So Mead and Baugh developed a framework for patient-centeredness as a style of interaction and communication with patients, whereas Stewart construed patient-centeredness as a more comprehensive approach towards patient care. And this included elements of health promotion. I think all these concepts that we can see on the slide are valuable to us as patients, and they're also valuable as approaches that patient-centered clinicians would endorse. So the Commonwealth Programme for Patient-Centered Care was launched in 1987 to promote patient-centered approaches to hospital and health services, focusing on patient needs and concerns. And this has evolved over time to encapsulate 8 dimensions of patient-centeredness that you can see listed here as a comprehensive way to deliver healthcare services. Here we see the key features of patient-centeredness at an organisational level. And this is further to the interpersonal relationship that we would have between patients and healthcare providers. So in 1987, I was working in Iraq, which at that time was a war-torn country. And when I reflect, actually some of the environments I worked in there were superior to some of what I've experienced in the UK. And so whilst many concepts are important to patient-centeredness, I think we do need to pay attention to creating the right environment, because the environment also makes a big difference to how we feel and function. So the PICA principles have informed something called patient-reported experience measures. And I present an example here of a rheumatoid arthritis patient-reported experience measure, or PREM, which we're currently working to modify at our unit in Exeter to use with people with interstitial lung disease to evaluate their care. And this might be something that you're interested in helping with, but this is a way to evaluate the consultation and to ensure that your consultation has in fact been patient-centered. So thinking about how we capture patient report, we've moved, particularly in the context of COVID, to supported self-management, and that's the key thing. It's not about self-management, it's about having supported approach. So working with your clinician to find ways that you can perform some aspects of care at home, but feed back to your clinician so that that support network is maintained. And a lot of the time this relies on digital connections, which can sometimes be problematic, can sometimes run smoothly. And not everyone is confident and comfortable with devices, so it's thinking about what is appropriate for you, and again taking a patient-centered, individualized approach to look at everybody in the context of their healthcare, and to thinking about how those connections are best maintained. And the trend is always our friend in these situations. And so when you're perhaps engaged in a home spirometry program, it is important to maintain connection with your clinician and feed back your FEC recordings, so that we can look at trends overall and decide whether or not, in fact, you may need to come in for a review in a hospital setting. And all patient-centeredness requires holistic involvement of the interdisciplinary team, and Professor Hurley talked about this a little bit. There is a multidisciplinary team which is key to diagnosis, but there is also an interdisciplinary team which play a fundamental, important role in ensuring holistic care can be delivered. And I think that this list is probably not exhaustive. And particularly in the current climate, I think patient advocacy has never been more important, and patient advocacy organisations such as ILFA are fundamental to ensuring that we can maintain patient-centred approaches. So let's think a little bit more about communication and interaction. And I have presented this model previously at a Patient Information Day for ILFA, but I just wanted to go here again and think about a communication model that Roger Neighbour has proposed quite some time ago now, but this is a model that medics might use in terms of learning how to communicate with patients. And so we always start with connecting and building rapport. But this is, I guess, both sides, from clinician and the patient perspective, because it's often in these first few minutes of meeting that we both decide whether or not we're comfortable with one another in the context of the consultation. And so I guess it's good for the clinician to look at the consultation through the patient's eyes, but also from a patient perspective to see it through the clinician eyes as well, to help improve our communication. In terms of summarising, we should be ensuring that you as the patient have given us clear understanding of what your needs are, but equally, if you don't feel that your needs have been understood, this is a time to speak up, to ensure that you're getting the most out of the consultation. Handing over should ensure that you feel well equipped to depart, and you feel informed and sufficiently confident of the management plan relating to your care. And this will include shared decision making and sharing responsibility. And again, if you feel that this has not been achieved, it's important to speak up. Safety netting is a checkpoint for both sides to ensure that any uncertainty is addressed, particularly in the context of interstitial lung disease, perhaps thinking about the unpredictable nature of exacerbations or the unknown potential side effect of medication. And then housekeeping is around taking care of ourselves and our well-being. And so at this point, I would certainly recommend that you pay attention to how you're thinking and feeling as a result of the content of the discussion, of the consultation. Shared decision-making is an important part of this, and it's evolved as a field of research, and the National Institute of Healthcare Excellence have now produced a guideline around shared decision-making, which had patients involved in the panel. And a lot of work has been done on this in the primary care setting. And so I think there's a great deal that we can learn and develop further. And it's important that you do feel part of the decision making in your consultation. And if not, certainly ILFA as an advocacy organisation can help you to ensure that future consultations are more shared in approach. So thinking about where we're at now, with an increasing trend to move towards digital consultations, it's important for us as clinicians to recognise that a lot of people are not that comfortable with digital ways of communicating, and may come to the consultation feeling a little bit flustered, particularly if you've been in a digital waiting room. And therefore, there is a need to personalise this connection even more, and thinking about concepts such as digital warmth and creating empathy, so that people do feel able to relax and talk. And for you as a patient, it's important to make us aware if, for example, you live alone, or if you've got someone else on the call, so that might shape the sort of discussions that we have. If you're using devices to monitor your condition at home, really important to understand what the parameters are and what the thresholds for change are when you need to notify us and seek further advice. If you are using any devices, that they're regularly calibrated, and ask your clinician how this might be done. And also try and feel empowered to volunteer how you're feeling psychologically. It's been an awful long time that people with interstitial lung diseases have been shielding for, and so psychological well-being is ever more important. And oxygen assessment, often difficult to do over the phone, so really essential to tell us about any change in symptoms around breathlessness, cough, fatigue, and fever, particularly because we cannot feel and often cannot see, and so we rely much more on the patient report, and so do take time to make us aware of this. And if you're worried about increasing breathlessness, ask about assessment for oxygen, or a reassessment of oxygen if you think that your requirements may have increased. So a little bit about holistic care. Recently published is a patient-centred outcomes research in interstitial lung disease statement from the American Thoracic Society, which I was involved in, and this identified that patient-centred outcome essential components are health-related quality of life, psychological and emotional well-being, symptom experience, functional status, oxygen needs, hospitalisation, and acquisition of knowledge. And so hopefully moving forward, these are concepts that will be included in clinical trials and research endeavours, but they are also relevant to clinical care. And thinking about health-related quality of care, this is a diagram that was included in our paper on the quality of life in sarcoidosis. And it is all inclusive, and these are aspects that impact on your physical and psychological well-being. And again, factors that should be brought to the consultation, whether that's with your clinician or your clinical nurse specialist. And again, factors to be aware of as they decrease or increase, and how that might impact on your core physical health. Thinking about breathlessness, which is a symptom that's common to most interstitial lung diseases, it's certainly a symptom that's worthy of a holistic assessment by the interdisciplinary team, given that it has both psychological and physical components. And it's important too that this is something that you recognise the psychological and the physical impact of your breathlessness. And ways that we can manage that are often through non-pharmacological approaches such as singing. And in fact, you'll be aware through ILFA, there is a project going on at the minute to evaluate how singing can positively impact living with interstitial lung disease. And there is a body of research emerging around this, and another big trial going on out of the Brompton in the UK in partnership with Brunel. Other non-pharmacological approaches include exercises such as yoga, and again, a little bit of evidence is starting to emerge around this. I just wanted to mention in this regard, and thinking about holistic approaches and what we know that patients want from symptom support and palliative care. We had some very good news this morning that a paper relating to the first World Cafe event to determine palliative care needs of people living with fibrotic interstitial lung disease has been accepted for publication in the BMJ Supportive Palliative Care Journal. So thank you very much for Nicola for your tenacity and hard work in driving that through. So essential components of patient-centeredness relate to providing a clinical environment for communication and a physical environment that makes one feel better. Integrated care from interdisciplinary team, thinking about collecting patient-reported measures and how we feed that back to you as a patient and someone completing these measures, that we're cognizant of family impact and support people to have access to patient advocacy organisations. Important that we see the patient as a person, but also for you to see the clinician as a person that might be impacted by previous experiences that they bring to the consultation. And that there is truly a movement towards sharing power and decisions and responsibility so that we can build a truly therapeutic alliance. And use of terminology is perhaps something to be debated at another time. So thank you very much for your attention.
Thank you, Anne-Marie. Justin, will there be any questions?
Yeah, there's a couple of questions. I know Killian has been busy answering a load of questions there in the background. But Brian has asked, my coughing has increased lately. Have you any tips to help with additional coughing?
Yeah, coughing is such a difficult one to manage. I think probably requires an individualized approach. I think in general, it's good to be cognizant of other factors that can exacerbate cough, such as postnasal drip, and sometimes there are over-the-counter medications for that, and that might be one to discuss with the GP as well, because there are prescribable medications. I think the cough can often be troublesome in the morning. It can be more of a wet cough and requiring a lot of phlegm clearance. And my advice would be that if that's your experience, is take your time in the morning, not to rush, but just allow yourself to clear that cough and clear that phlegm. To have lots of sips of water. Your dentist might not approve, but sometimes sucking on a variety of mints can help. And also distraction therapy as well. But often the breathlessness and the cough can be very much interlinked. And physiotherapists can be a good person to approach for particular tips relating to your individual context on how you might better manage.
That's great. Thanks a million for that, Anne-Marie. Back to you, Eddie, for our next speaker.
Thank you, Justin. Our next speaker is Dr. Kate Devenney. And Kate is a clinical specialist physiotherapist at the Respiratory Assessment Unit at St. James's Hospital. The Respiratory Assessment Unit provides services to people with chronic lung conditions, including pulmonary rehabilitation, self-management plans, oxygen assessment, and ongoing telephone support. Kate also works part-time at the University of Limerick, supporting and teaching physiotherapy students on clinical placement. Kate's presentation is called Exercising with Chronic Lung Disease. Start moving and keep moving. And on that note, I'll hand over to you, Kate. Thank you.
Thank you very much, Eddie. I will just pull up my slides.
Yeah, that's perfect.
Is that all okay there, Justin?
It's just on the. It's on the. Yeah, we can see all your notes.
Okay.
Yeah.
So I'll take off the. I don't know what.
Just give me one. If need be, I can pull up the slides here.
I think I have one without notes as well. Let me
Okay.
see. Yeah. I'll just open that.
I have them here, Kate. If need be, I can.
Yeah, I'll just think I've taken them out. How is that?
That's perfect. Yeah, that's perfect.
Okay, I'll get started as I know we're approaching coffee break. So thank you very much to Gemma and everyone at ILFA for inviting me to speak today. As I said, my background is a physio in St. James's, and in this year we collaborated with ILFA and a group of students where I supervised a group of students from the University of Limerick to deliver and design a 12-week online programme for patients with pulmonary fibrosis. So I'm very delighted to be here to talk to you today about exercising with a chronic lung disease. And today's talk is going to focus on giving you some tips on really how to start moving and how to keep moving. And hopefully I can answer some of the questions that have come up in the comments section already today. So firstly, just to talk briefly on exercise and physical activity, as these are two terms you might hear interchangeably used in relation to exercise training. So they're both very beneficial for overall health benefits, but they do differ slightly in what they are trying to achieve. So exercise is by definition a planned, structured, intentional and repetitive movement that's overall aim is to either improve or maintain an aspect of physical fitness. So that can be anything like your muscular endurance or your muscular strength or your cardiovascular fitness. Physical activity then is defined as any movement that is carried out by the muscles that requires energy. So it's basically any movement that a person does. And by physically active, we can be describe people as being either sedentary, where they're spending a lot of time sitting. They can be low active, moderately active, or kind of vigorously active people. And in both healthy adults and chronic disease populations, we have numerous studies that have shown very significant health benefits in people who have higher fitness levels, exercise regularly, in addition to being physically active. So just briefly to recap on exercise, in case any of you forgot what the benefits of regular exercise are. So those who exercise regularly will feel less breathless. They will have improved circulation. It helps to maintain a healthy weight, in addition to improved muscle strength and endurance. It also improves the quality of your sleep, well-being and mood. It can boost your immune system, improve your balance and reduce your risk of falls, and improve your bone mineral density. In this slide, I'm going to just briefly discuss the cycle of breathlessness and inactivity. And this was something Killian touched on in his talk already. So you may have noticed yourself over the last number of months or years since your diagnosis that you've had to slow down activities such as walking. You may have to find that you stop going up the stairs or curtail some of your activities around your house or in your garden because of your breathlessness. And when you slow down or stop these activities altogether, you inevitably lose fitness. So by being less active, your muscles become weaker, and weak muscles use more oxygen and are less efficient. And this in turn causes people to feel less breathless, or more breathless, should I say. And they then become fearful of doing activity that's going to make them breathless and avoid activities that make them breathless. So you can see what we term this is the vicious cycle of breathlessness, or the cycle of breathlessness and inactivity. And one thing I would like to acknowledge in this slide is that the psychological impact this has on patients. So it does make patients fearful and avoiding certain activities. And one thing people can do to try and help break this cycle is through regular exercise or a more formal program of exercise and education, which is known as pulmonary rehabilitation. So if we look a little bit more specifically at pulmonary fibrosis, as has already been mentioned by the speakers before me, pulmonary fibrosis is characterized by a number of structural changes within your lungs, by which your lungs become stiffened and hardened. And this in turn leads to what we call physiological changes as to how your lungs can function. You get reduced lung volumes and lung compliance, which affects the amount of air that you're able to move in and out. This can lead to breathlessness, impaired gas exchange, the ability to get oxygen into the body. And this all in turn can reduce what we call your exercise capacity. Although exercise training will not improve your lung condition, it does improve your cardiovascular conditioning and the ability of your muscles to use oxygen. Numerous research studies have shown in patients with interstitial lung disease and pulmonary fibrosis that exercise improves your exercise capacity, it will decrease your shortness of breath, and it will improve your quality of life. An important thing that is consistent across these studies is that exercise is both feasible and safe. This slide just shows some of the research evidence out there that I used to inform my talk today. And I'd like to draw your attention to this bottom slide here, which is what's called a Cochrane review, whereby a very specific research question is asked. They collect all the relevant studies to answer this research question and summarize it all to make a recommendation. And in this research study, they asked whether pulmonary rehabilitation was beneficial for patients who had interstitial lung disease. In this review, they had 21 studies included in patients with interstitial lung disease and 9 studies in patients with just idiopathic pulmonary fibrosis. So they found in this review short-term clinical improvements in exercise capacity, in quality of life, and in reducing breathlessness in patients with IPF. So based on the current exercise training data we have sufficient clinical evidence to recommend it as a standard of care in pulmonary fibrosis. And this has been reflected by the Irish Thoracic Society position statement on the management of IPF, in which pulmonary rehab should be embedded as part of the patient pathway of care. And it was interesting again in Killian's slide that only 38% of patients said they'd been referred to a pulmonary rehabilitation programme. I'd like to also acknowledge here that there is still some further research gaps and things that we still need to determine. These are, one, the optimal exercise prescription. That is exactly how much exercise patients should be doing. And the second thing we don't know is to investigate ways to promote longer lasting and sustained improvements in patients with pulmonary fibrosis. So in the absence of a specific exercise guideline for pulmonary fibrosis, we follow the international guidelines from the American College of Sports Medicine, which recommends the following as your weekly prescription of exercise. The first type of exercise is what we term aerobic exercise. This is any exercise where you get your heart rate and your breathing up. Over the course of a week, you're advised to achieve 150 minutes of moderate intensity type exercise. Breaking that down, that would look like 30 minutes, 5 days a week. The second type of exercise to complete is what we call resistance or strengthening training. And this is a type of training that requires the muscles to work or hold against an applied external force. This can be by using a machine, a weight in your hand, a body weight, or a resistance band. And this type of exercise makes your muscles more efficient at using oxygen. The final types of exercise that you might include in your exercise routine would be flexibility, stretching type training, in addition to balance exercises to help reduce any risk of falls. And I'd like to emphasize here that exercise will look different for everybody, depending on the severity of your symptoms and your disease. So while for some people aerobic exercise might be going out for a brisk walk, for others that might mean going out for a slow paced walk, whereby they're still getting the same exercise stimulus. And again, for some patients, aerobic exercise might have to be performed in a seated position in a chair. So just to acknowledge that as well. And if you have pulmonary fibrosis, exercise might be a bit difficult. And I've noted that in some of the comments from attendees today. The importance here is to plan your days. So plan where exercise can fit into your routine and try not to expend all your energy in one day. So the thing about exercise is you need to make sure you're getting the right intensity of exercise. And this here is what we call the modified Baugh dyspnea scale or breathlessness scale. And this is what we use in pulmonary rehab to monitor people exercise intensity. You can see here that the scale goes from a 0 being not breathless at all, and it rises up incrementally right up to 10, which is absolute max. When you're exercising, you should aim to achieve a breathlessness score of either 3, moderate, or 4, somewhat severe. What this means is that if you find your breathlessness climbing higher into those very severe category of breathlessness, it means you need to stop, slow down, and pull back the level of effort that you're putting into your exercise. Similarly, if you find that you're not getting any stimulus from exercise, you're only feeling slight or very slight, you're not moving enough or vigorously enough to get the right level. So this is what we use, and it's a nice, very simple tool that will make sure you're getting the right intensity of exercise. Again, the principles of exercise training that we apply are something called progressive overload, where you have to start low and build slow in the frequency you're doing it, in the time, and in the intensity and the type. So really start at something that's going to be manageable and achievable for you, and slowly build it up over time to get what we said, those 150 minutes per week and resistance training on 2 days per week. So if you have any concerns about exercise, or you've been completely sedentary, you may wish to consult your doctor before starting an exercise program. Again, just some points to note on exercising safely. And again, a lot of these would be common sense. So avoid any exercise if you're feeling very unwell or have a flare-up or an exacerbation of your symptoms and condition. Secondly, use oxygen while exercising if it is being prescribed to you. So oxygen is there to try and help you be able to do more and exercise more. So use it appropriately while exercising. And thirdly, just to pace yourself while exercising and allow yourself some recovery time between exercises as you need. And finally, stop exercising if you experience any of the following symptoms: chest pain, dizziness, fainting, or very severe breathlessness, and seek medical advice. So if exercise is so good, makes everyone feel good and has so many benefits, why don't we all do it? And this slide just acknowledges some of the barriers to exercise that have been reported. Things that have been reported as barriers to exercise for people include things like motivation, level of cognition, poor self-efficacy, which is the belief that you're able to do something, and poor coping skills, psychological stressors, things like weather, financial issues, family issues, home environment, and logistics. But again, if we look at that in chronic respiratory disease populations, there are also things that are noted as being facilitators to exercise. So what will facilitate you to exercise? Things like social and peer support have shown to be very powerful. Again, professional support from healthcare professionals like physiotherapists and pulmonary rehab programs. And again, kind of patients who have higher levels of self-efficacy, belief in themselves, will also be more likely to exercise. And another key feature that can help you to exercise is to set yourself goals. And I'll talk about that in a moment. So the European Respiratory Society conference was on just last week. And one of the talks I went to was about people that exercise or attend pulmonary rehab. How do they maintain those benefits over time? And they found that patients with interstitial lung disease who do not continue to exercise will lose the benefits of pulmonary rehab after 6 months than those who continue to exercise. So if you're not consistent, if you don't continue to exercise, any benefits that you gain in your exercise capacity, in your breathlessness, in your quality of life, they will wane over time back to where they were. So it's really important that it's a consistent approach we take. Another thing I want to mention here is individual preference. So everyone will have a different preference for how they'd like to exercise, whether it's putting on a podcast, going for a walk, doing an online class, going to the gym by yourself. So it's about trying different things and finding what works best for you. So goal setting is something that you can use to help improve your adherence and likeliness to continue. So we're more likely to achieve a goal if 1, we're clear in what we want to achieve. 2, the goal is realistic, so we break it into smaller steps. And 3, if we write it down or tell someone for accountability. So it's good just to try and set yourself short-term goals, long-term goals, and that again can try help motivate you as part of your exercise program. Okay, finally, I'm sure you all want to get started with some exercise now. So in the next few slides, I'll just give a very brief overview as to what is available for exercise. So the student group I worked with from the University of Limerick made this resource. It's a YouTube channel called Fit with Fibrosis. It has a warm-up, a cool down, it has resistance exercises, aerobic exercises, and they've broken it into kind of beginner, intermediate, and more advanced level exercises. They also have a nice video on this about how to manage breathlessness and exercising safely. So again, that's something that can be accessed freely. The British Lung Foundation similarly have free videos that you can access online. And again, a nice thing about these exercise videos is that they're level 1, level 2, and level 3. So depending on your current level of breathlessness, you can follow whichever video you feel you most fit into, so you can get the right type of exercise. And again, these are freely available online. It would be remiss of me to be at today's talk without mentioning the fabulous work of ILFA, along with Gordon Cagney, a physiotherapist at University Hospital Limerick. There is online classes every Monday and every Thursday at 11, and you can contact ILFA through the email address or the contact number to join the classes. And again, there's been huge interest in this. The final slide is just pulmonary rehab, because it's something I've mentioned throughout this talk. And the students I worked with from UL tried to contact kind of hospital sites around the country to establish if they accepted patients with a diagnosis of interstitial lung disease and what their current status was on rehab. Now, this is a little bit dated. It is from March of this year, so things have been evolving rapidly. But you can see here, there's 14 different sites that they were able to establish around the country that take referrals for patients with pulmonary fibrosis. To finish, I just have 3 key take-home messages. 1, exercise is safe and it's effective in pulmonary rehab. The second thing is that movement matters. Exercise will demonstrate improvements in your exercise capacity. It'll help reduce your breathlessness, and it will help improve your quality of life throughout different stages of your disease. And finally, find what works for you and start setting yourself some goals. Thank you very much for listening, and I welcome any questions.
Thank you, Kate. That was most informative.
There's a couple of questions, and I know I'm eating into the coffee break time there, Eddie. So I know that our speakers are answering questions in the background on the Q&A box there. Just one quick question. I take in oximeter readings when exercising. Sometimes they go down to, sometimes they go down to 80 or below, and I get very distressed. Is there any recommended reading to try and avoid going below?
It can be difficult in patients with pulmonary fibrosis. I would recommend, if you could get a referral in, there's a number of oxygen clinics that will assess your need for portable or supplemental oxygen while you're exercising. And that sometimes you need to have ongoing review where they might need to increase the amount of oxygen to make sure you're getting the right amount. I would say we generally use kind of 88 as our kind of benchmarker when we're in rehab classes. But then again, not to worry, if it does dip down to 80 or below, once you stop exercising, it will come back up over a period of time. So not to worry that it will recover back up to whatever your resting levels are. But I would recommend, if you're not using portable oxygen, to seek a referral in for assessment.
Thank you very much, Kate. I'm going to hand it over to Eddie now. We do have a lot of questions coming in, Eddie, but the speakers have been answering them in the background there, which is great. So, yeah.
Right, at this point in time, I think we're all due a 5-minute coffee break or so. So if it's just a little comfort break for everybody, and we'll see you, say, in about 5-7 minutes time.
Perfect.
Thank you. Welcome back, everybody. Our next speaker is Monica Devine. Monica is an occupational therapy manager at Clontarf Hospital in Dublin. Monica has worked in a variety of settings, including rehabilitation and palliative care. She is a member of the Association of Occupational Therapists, National Older Persons Advisory Group, and the National Occupational Therapist Managers Advisory Group. Monica's presentation is entitled, "What do occupational therapists do?" So on that note, I'll hand over to Monica. Thank you.
Thanks, Eddie. And thank you there for the introduction. And I'd like to thank Nicola for inviting me to speak today. From speaking to Nicola, I think, am I the first OT that's spoken at the ILFA Patient Information Day?
That is possible. That is possible.
He's nodding her head there, yeah.
Yeah. So hence, I'm just going to figure out how to share my screen. Hopefully this will work. Did that work?
That's it. That's up. Yep. Perfect.
Happy days. I've never done this before, so I'm delighted. To anybody who's still trying to finish their cuppa or their snack work away, I won't be bothered like that. So as I said, as I think I'm the first OT to speak, and from speaking to Nicola before today and what Prof. Hurley referred to earlier on, it sounds like for a lot of patients with lung fibrosis, there's very little access to occupational therapy. I think as many as 45% aren't referred to any HSCP services, but only 8% have been referred to occupational therapy. So that's a really low number. So I've entitled my presentation today, "What do occupational therapists do?" As I'm assuming there's a lot of people attending today that don't have any idea that what we might do or what we can offer to patients. Hold on. And trying to fit there. Couldn't figure out to change the slide, have it. So what I'll cover today is what is the role of the OT in the hospital and in the community. So we tend to do different things, whether we work in the hospital or in the community. And I'll speak about kind of the broad strokes. So what do we mainly do? There's a lot of kind of specialist pieces that OTs can offer for patients with lung fibrosis, but today I'll speak about kind of the main role that we do. How do you get to see an OT? So after hearing to me speak today, if you think that occupational therapy might be of use to you, how would you actually get to see one? What are some of the common environmental adaptations the OT can help with around the house? So what are the things that we generally recommend that you might do at home? And if we do make recommendations around changing your home environment, are there any grants available to help with these adaptations, because they can be expensive? So the role of the OT. So OTs should help you to do things that are important to you and that are meaningful to you. So we will help with things like bathing, dressing, eating, leisure, sleep. It's a really kind of broad role. And we'll do this through kind of education, aids, and the modification of the environment. So by changing your home environment to make things easier and safer for you to do. So as I mentioned, the occupational therapist, whether they work in the hospital or the community, they might do different things. So within the hospital, the OT is focused on kind of getting you home as soon as possible and as independent as possible. So what we would look at would be helping you with daily tasks such as washing, dressing, and cooking. So this would be you primarily doing it for yourself, but what's the techniques in how you wash, dress, and cook for yourself? How can you make it easier? How can you waste less energy doing these essential tasks, just to break it down for you? We would often do a lot of work with kind of energy conservation. So looking at your energy as a budget over the day, how do you best spend it by doing the things that are most important to you, and stress management. The hospital OT will also refer you to a community occupation therapist if you need to be seen at home. And I suppose just don't be afraid to ask to be seen by an OT. It sounds like the referral routes, particularly within hospitals, aren't established yet in Ireland. So by asking, that's how services become available. When looking at the community occupation therapist, so the community OT, and they're also referred to as the primary care OT, they'll come and assess you in your home, and they will make recommendations of how you can change your home to make it easier for you to use it. They'll often give you equipment to make daily tasks easier for you to do, so you waste less energy doing some essential daily tasks. And the community OT will also help with OT reports for kind of grant applications or housing adaptations. Is that okay? Yeah. So how do you see an OT? And I've just entitled this, Where Are They Hiding? So we can kind of be an elusive profession. You might see somebody run around the hospital with green trousers or a tunic with green trim. And in the community, obviously, we'll wear civvies, but they can be hard to access. So you can ask to be seen by an OT in the hospital. The service mightn't be fully established, but by asking for this, I suppose that's how service becomes established and how a clinician will get assigned to a clinic. Within the community, you can ask for your GP or your public health nurse to refer you to a community OT. And as I said earlier, they're also called primary care OTs. The wait lists, unfortunately, they can be really long. So look for a referral for yourself or somebody that you care for. Look for a referral early. And once you know you're on the list, if your need becomes more urgent, don't be afraid to phone up your local health centre to ask where you are on the list and trying to get bumped up if your need is more urgent. If you see an OT in the hospital, they can also refer you out to the community OT to be seen. If you want, you can access an OT privately. Obviously, there's a cost associated here, but there are kind of a list of private OTs on the website of the AOTI. I have the website address there. So often patients will see an OT privately if they have an urgent need for the likes of an OT report for a grant. And if you do this cost is usually refunded in full or mostly in full by your county council. So just to speak about kind of the home adaptations, what do we often recommend doing? So if you are referred to an occupational therapist and they come to visit your home, what are they going to look at? Because patients are often nervous about what OTs might be looking at in the home. So I'm going to talk through some of the general areas that we would look at and some of the general suggestions that we would make. These would obviously be very specific to your own needs, but these are kind of often the things that we do suggest. Sorry, just trying to get my coffee into me too. So the first thing we'd look at would be kind of access to the home. How do you get into your house? We'd look at the kitchen environment, the bedroom, the bathroom, and the stairs. So that's what I'm going to speak about now. So looking at access to the home. So this is, how do you get into your home? Is it easy for you to do, and is it safe for you to do? So if you have steps to get into your front door, so the OT will often have a look at you kind of getting up the steps and to see how you're managing with them. We might recommend something like a grab rail on the wall. We might recommend a metal railing on the steps or the stairs. If you have a really uneven driveway, we'll usually recommend that that's made smooth if possible so that holes or uneven surfaces are repaired. We'll often recommend that you have good lighting outside your front door and your back door so you're less likely to have a fall in those areas. If it's wet or icy weather, we'll generally recommend that you take extra care. That's common sense. And to not load yourself with shopping bags. So this is more from kind of an energy conservation angle. So if you can get your groceries delivered into the kitchen table, or to use an outdoor walking aid if that's something that you do use to carry kind of small loads of shopping. So that's looking at the access in the front door. Looking at your kitchen environment, we'll often recommend that you keep all the things that you commonly use. So beside your kettle, to have your coffee, your sugar, your tea bags, a few mugs out on the counter. Keep them kind of easy to access to avoid unnecessary effort. You can see the pictures there on the bottom of the screen. We'll often recommend something like a Buckingham caddy that's on the left, or the kitchen trolley on the right, to kind of carry things around. We often suggest to use countertops to support yourself if you need it, but make sure they're strong enough to support you. To clean up spills in the kitchen immediately, or ask somebody to do it for you if you can, just to reduce the risk of slippage. As I said earlier, the OT in the hospital will often practice kind of making meals with you. However, if main meals such as dinners, if they become very effortful and you'd prefer not to spend your energy on making meals, and you can consider something like Meals on Wheels, or there are kind of lots of different food prep companies to make meal prep easier, if that's something that you choose to do. So looking at the bedroom, obviously we'll be looking at how easy is it for you to get in and out of your bed safely. Is there any kind of aids or adaptations we can offer to make that easier or safer? We will often suggest that you have a bedside locker with kind of a light, your glasses, pendant alarm if you have one, your phone, your mobile phone or cordless phone beside you if you need to call for help. To get out of bed, to take your time, to make sure that your bed is a good height with a nice firm mattress, and your OT, they will advise you on a suitable bed height. So I know the kind of modern beds are like really super high, and older beds used to really low, so it's about getting kind of a good height so it's easier for you to transfer from the bed. To watch out for kind of loose sheets or clothes to avoid, I suppose, slipping and falling out of bed. If you use a mobility aid, to have it beside the bed. The physio will often recommend having one upstairs and one downstairs, so it's easier for you to get close to them. If your bedroom is very far from a bathroom, it might be that you consider having a commode in the bedroom to make nighttime toileting easier. Looking then at the bathroom, so the main things we're looking at here will be how easy is it for you to use the toilet and the shower or the bath, and what can we change to make it easier or safer to do that. We'll often recommend kind of a non-slip mat in the bath or the shower. We might suggest something like a shower chair or grab rails. You can see some of the toileting equipment there at the bottom of the screen. So on the left, we call that a toilet surround frame. So that's to give you bilateral support when you're getting up from the toilet. And on the right, we call that a raised toilet seat. So that makes a toilet higher, so it's easier then to get up from. So a toilet that you'll typically see would be like 16-inch height. Add in a raised toilet seat, or if you buy a comfort height toilet, as they're now called, and they tend to be 18 inches, which is just easier to stand up from, and you waste less energy doing so. Never to use a towel rail or a radiator to help yourself get up. To leave the bathroom door unlocked so somebody can get into you if there's an emergency. To wear your pendant alarm if you have one. There are financial supports to help with pendant alarms if that's something that you are interested in. And if your bathroom is just unsuitable, so if you need a complete bathroom renovation, your OT will advise you on kind of grants that are available to support you to do this. Looking then at the stairs, so the main thing we'd be looking at is, can you use the stairs easily and safely? We'll recommend that you keep it free from clutter, to always use the banisters or the rail. If you've been seen by a physio, they'll often give you a particular technique to go up and down the stairs safely and easily, so to use that technique. If you need a second stair rail or a stair lift, we'll suggest that and advise you how to go about it. Dublin City Council and nationwide, all councils do provide housing adaptation grants for stair lifts, and to not carry anything on the stairs that requires two hands. We'll often recommend to wear like a crossbody bag if you want to carry a book up the stairs, or rather than carrying a cup of tea up the stairs, to bring it up in a travel mug again in a bag, so your hands are free to hold on to the railings. So looking then at the housing grants, so that I've kind of listed 4 here that are the main ones. The first one there is the one that will be most commonly used, and we refer to it as the HAG, so the Housing Adaptation Grant Scheme. So this is only for private homeowners. The maximum grant is 30 grand, and it's to help kind of large building works to make accommodation more suitable for the needs of the applicant. So this would be things like that OTs would often recommend. So a stair lift, an access ramp, so that's a ramp to go in your front door, a level access shower, that's a shower with no step, so you're less likely to have a fall and it requires less energy to get into the shower, a downstairs toilet, garage conversion, kind of a whole plethora of things. Now 30 grand wouldn't cover, a huge amount of work, but it'll definitely contribute towards a good chunk of the cost. You don't always need an OT report for a HAG application. You need an OT report if you want a stair lift, and you need an OT report for a bathroom, but only if the bathroom is an extension onto your property, or if a different room is being converted into a bathroom. If you already have a bathroom and you just need to make it level access shower or put some adaptations in, you actually don't need an OT report for that, and that's a common misconception. So you can go ahead with some of this work without an OT report. So just to contact, I suppose, your relevant council regarding documentation for the HAG. The second most commonly used scheme is referred to as the MAG. So again, this is for private homeowners. This grant is much smaller. It's only up to €6,000. So this is to cover like a smaller piece of work. So typically, often patients would use this to contribute towards the cost of a stair lift, if that's all they want at the moment, and to save the HAG for something kind of larger down the line if they know that in time they might want to put in a level access bathroom to save the HAG for a bigger piece of work. So again, to contact your local council for terms and conditions. The paperwork is similar, but the process differs. Of course, we are in Ireland, so unfortunately the process differs from county council to county council. I've just mentioned the less commonly used grants, but just so you know that they're there. There is the HOP, so this is around kind of housing aid. So it's nothing to do with making your home more accessible. It's to do with making it safer if there's major kind of rewiring or roofing repairs, that you get some funding back to help make those repairs. You don't need an OT report for this because it's not about accessibility. It's just about making your home safer. And the last one I'm going to mention is just because most of the grants to date I've spoken about are around kind of for private homeowners. If you are a tenant, there is a DPG, Disabled Persons Grant Scheme, that is available for tenants. So you can make your rented accommodation safer and easier to use. Just a couple of notes on the grant schemes, because they are just notorious for being kind of like cumbersome to use. So it's really important to not start any building work until you have the grant through. So if you start building work, you won't get money back, for work that's already been completed. So you need to have the application complete, and it does take a long time before you start any building work. The second important point is that if you need a report from a grant, it can't come from a hospital-based OT, so it will come from a community OT, a primary care OT, or a private OT, so not from a hospital OT. If you're trying to get a report, you can go on a waiting list to be seen by a community OT, but as I mentioned earlier, this can be lengthy, so try and get on the list as soon as possible. And alternatively, you can employ, as I said earlier, the private OT. The report is usually in around €200, and it's usually in around €200 you get back from the council, so you get most of that back, but you do have to be able to pay that in advance to get the money back. So there is a private OT list, which would be useful for some people. Just for Dublin City Council and kind of general council information is the last bit of information I have here. Just a reminder again to apply early and prepare for a long process. I've gone through it for one of my own parents, and it just took forever, and I know the system. So just prepare yourself for a lengthy process, and the OTs will support you as much as possible, as will the rest of the MDT to get it through, but it's just long. If you have the appetite for it, apply for it much sooner than you think you or your loved one might need it, just to get it done and be ready. I've some further information there on kind of the Dublin services. And nationally, I suppose, just please contact your local council for information. Okay, that's me. That's a flying visit of occupational therapy and what we might offer. I'm open for questions.
Thank you, Monica. Very informing.
That's super, Monica. There's only one question that's come in here. Maybe people are being shy now. Who is the best person to talk to if the patient gets very stressed about having a shower or going to the bathroom, Monica?
I suppose if it's around kind of the environment of the bathroom, is it if it's the patient is getting stressed about kind of using the bathroom, that they feel unsafe, then it will be an occupational therapist. If it's kind of a psychological piece, it might be your clinical nurse specialist or a psychologist or your counsellor if you have access to them. So I suppose it depends on what is the cause for the stress. But if it's that the bathroom environment is inherently unsafe or not easy for the patient to use, it will be the OT that you would speak to about making the bathroom easier to use.
That's great, Monica. That's the only question that came in, and very informative. You covered every aspect of both private and the public ends of things.
That's right.
Yeah. Right, back to you, Eddie.
Yeah, thanks again, Monica. Thank you. Our next speaker is Professor John Baugh, an associate professor in medical science at the UCD School of Medicine and research group leader in the UCD Conway Institute of Biomolecular and Biomedical Research. Dr. Baugh has developed strong clinical collaborations in Dublin with particular focus on idiopathic pulmonary fibrosis, pulmonary hypertension, and other conditions. Professor Baugh was awarded a research bursary from ILFA in 2019, and we look forward to hearing about his research into the role of diet and gut microbiota in IPF. I hand over now to you, Professor. Thank you.
Great. Thanks very much, Eddie. Thanks for the introduction, and thanks so much for inviting me along today, and Gemma for organising. So it's a pleasure to be here. Let me just try and share my screen. Hopefully that's slides.
That's coming up perfect, thanks.
Great. One more click. Okay, yeah, so I want to talk a little bit, maybe about something completely different to the rest of the morning then, and a potential role for diet and microbiota in respiratory disease. My focus in my lab then, just getting the hang of the progression. So the focus in my lab then really is on this sort of central pathway that you see in the middle of the slide here. And as Professor Hurley alluded to at the very, very beginning today, we know in most patients, disease progression is related to an uncontrolled inflammatory response that's driving an uncontrolled wound healing response. And again, as we know at the time of presentation, the injury and the inflammation may be unclear or not present, but there's this uncontrolled sort of wound healing response that leads to the scar and obviously the fibrosis and the symptoms. So in my lab, we work on inflammatory cells, so monocytes, macrophages. These are cells in the blood that respond to injury and should normally coordinate a nice kind of wound healing response. And we work on fibroblasts, which are the cells that live within the tissue in the parenchyma of the lung, and are sort of important for building the architecture of the lung and the scaffolding that all the important cells live on. So we're predominantly cell biologists, and as Eddie mentioned, I was very lucky to receive a little bit of funding from ILFA that has helped us develop some work on how diet, and in particular diet-derived metabolites, and I'll talk about these a little bit more later, may influence the function of these cells. So for instance, that one doesn't show too clearly. So for instance, what we see on the screen here, and it's a little bit dark, apologies for that, is a picture down a microscope of some fibroblasts on a sheet of plastic. So you may be able to make out just on either side that there's a little bit like a fingerprint, swirl of a fingerprint, and those are the cells all bound together. And in the middle, we've scratched a wound with a pipette tip, so there's no cells in the middle. And if you just start recording a picture every 10 minutes, you see these fibroblasts slowly move in and they want to heal the wound. And obviously, it's a very, very simplistic experiment. But it just shows you these cells moving, and they want to move into the wound, and they want to produce the collagens and the proteins that form the scaffolding in the lung. So the inflammatory cells are important, and these fibroblasts are important in the scarring in the lung. The links with diet then, for me, and again, we've all heard a lot about diet, and we all, whilst we may love a burger and chips from time to time, we all know it's definitely not good for us. A lot of people argue it's very bad for us, but we know at least it's not good for us. And if you go back to sort of the 80s and 90s, there's obviously a lot of interest in dietary fats and cardiovascular disease. A lot of work done trying to reduce fats, and that brought kind of the sugars up, and then we kind of learned that high sugar drove type 2 diabetes, and that's a problem. And lots of the focus, I think, early on was on, well, what are the bad things in the diet? And I think there's been a shift now into thinking, well, maybe it's not so much that our modern diet is full of bad things, but maybe we're lacking some of the good things. And when we look at fruit and veggies, again, we all know fruit and veg is good for us. I mean, we've been telling our kids for generations to eat their veggies. But what's been maybe unclear until relatively recently is, well, why is fruit and veg good for us? And what we think now, many people think for the last maybe 10 or 15 years, is that the fibers, the fiber in the fruit and veg helps support the gut and the bacteria that live within the gut, this microbiota. And what we've seen over the last few years, and it's links between the diet, the gut microbiota, and initially gut health, and a healthy intestinal system. But then we see links with other organs, and obviously the topic for today being links with the lung. And I think this is where it gets a very, very difficult topic. And any of you that have, go to Google, and you can't help but being bombarded with information about microbes, good microbes, bad microbes. And if you go to the medical literature, what's a little bit hard to see is a little bit small maybe, but this graph at the top, it just shows you the number of publications per year related to the microbiome. And you can see that it's a relatively new field. So this is just the last 20 years. And now we're getting about 20,000 publications per year on the microbiome. So it's very, very topical. And that makes it very, very difficult for even people within the field to understand it. So what I wanted to do today really is just maybe touch on some of the key points that are maybe relevant to all of us in trying to maintain health. So the field has expanded dramatically, and these terms such as microbiome, microbiota, prebiotics, probiotics, postbiotics, I think they can be a little confusing. And what I'll try and show you then is just a little bit of data on the background of this whole story, and some evidence then showing you that maybe we should be paying attention to some of this and maybe looking at our diet. So in terms of the microbiome, again, I don't want to do too much background, but I think there's some really important points to take home from this. And originally, when the microbiome was first described, there was an estimation that actually, as humans, we were more bacteria than we were human. So we know that in our human body that there are about 10 to the 13 cells. There's a massive, massive number of human cells that make us function. But the early estimates were that there were 10 times as many bacteria as there are cells. So there was this kind of idea that maybe we weren't really that important. We were just here as little bioreactors, and it was the microbes keeping us alive, so they had somewhere to live. There's been a bit of revision there, so we now know it's probably more equal, but still, for every single cell in our body, there's a microbe. And just to put that in context, the current world population is about 8 billion. So there are more microbes in our gut than there are people on the planet. And again, I don't want to get too distracted, but you can imagine the complexity of the interactions and the communications between these bugs. They're all fighting for resources. They're all fighting for places to live. And of course, they're colonizing us. And it makes sense that, when they're upset, they can do things that upset us and vice versa. So of particular importance then, the gut microbiome contains about 2 kilograms of bacteria in your gut. And again, just to be clear, in technical terms, the microbiome includes viruses and fungi as well, but for the purposes of today, I'll just focus on bacteria. And we know that our skin is colonized, all of our mucous membranes are colonized with bacteria, but the greatest number of bacteria are in the gut. And their job, well, if you like, I mean, that's a bit incorrect maybe, but what they do there is they live on the byproducts of our food. So they live off of what we don't want. And there's this fantastic symbiotic relationship where the bacteria will use some of the food that we can't digest, and they produce molecules that keep them happy, and they produce molecules that keep us happy. So for instance, when they break down and ferment fiber, they produce energy that the cells that line the gut use as an energy source. So it's a really nice symbiosis. They break down something we can't, and they produce energy for the cells in the gut. So a lot of those thousands of early papers were sort of focused on gut health and the relationship between the microbes and the healthy gut. But we now know that these molecules that are produced get into the body, circulate in the blood, and can affect cells anywhere within the body in any tissues. So in terms of the shape, then, the profile of this microbiota or microbiome, so it's obviously a massive population, thousands of different species of bacteria. So when somebody says, well, this is a particularly good one or a particularly dangerous one, it's a very, very difficult thing to understand. But what I think is very, very clear is that there's a large population of bacteria. And depending upon our diet, of course, you can provide the nutrients that the bacteria like. So for example, in a high-fat diet, we'd see a shift in the profile because only certain types of bacteria can break down fats. Only certain types of bacteria can break down the proteins in a high protein, high meat diet, and only certain types of bacteria can break down the fibers in a fruit and veg. And of course, the underlying theme of all of this so far then is that the modern diet is a low fiber diet, and this is causing what is called a dysbiosis. And a dysbiosis simply means an imbalance. And an imbalance can be caused by diet, or it could be caused by disease. But what we're seeing is in patients with many diseases that there's a change in the profile of bacteria within the gut. And of course, we're trying to see if those are causal links with disease or whether it's just a coincidence. In terms of the shape then, and again, don't have time to go back 85 million years, but you know, if you're reading about microbes and diet, then people will often talk about the paleo diet and this kind of hunter-gatherer diet, which I think, you know, there's a lot of interest in it, and that there's a strong theme of relevance throughout it. But you know, if you go back as far as that, they probably weren't eating avocado toast and grass-fed buffalo steaks. But the point of the slide really is just to iterate that our diet has evolved for probably about 1 million generations of hunter-gatherers. And it's only really in the last 4 generations that the Western diet has evolved. And of course, you know, we see the high fat, the low fiber, and what we are worried about is that over generations now, we're losing the beneficial bacteria, so they're becoming extinct. And the concern is that, you know, we need to try and protect these bugs to keep them doing their healthy activities. So fiber I've talked about a little bit. So just to clarify then, that when we think about dietary fiber, there are 2 main types of dietary fiber. There's fiber that's insoluble. And again, that's probably the one that we're most aware of. It's the one that keeps you regular. So, you know, whole grains, roughage, brown bread, bran flakes, that type of thing. But there's another type of fiber called soluble fiber. And luckily, it's in the same types of places in your whole grains, your fruit and your vegetables, but it's soluble, so it'll dissolve in liquid. Now, our digestive system can't break it down, so we still can't use it. So it is a fiber, but it's soluble. So that comes from things like pectin in fruits, glucans in oats, inulin in wheat. And if you buy these as supplements in a health food shop, that's the type of thing you'd be getting, like ground up chicory root extracts from inulin and things like that. But all of our vegetables, whole grains, and fruits. And the particular relevance then of these soluble fibers is that they form the fuel that these bacteria can break down to produce energy for themselves. And in doing so, they produce these short chain fatty acids, these molecules that are produced in the gut, provide energy to the cells in the gut, and then get into the blood and circulate. In terms of the profiles then, so again, as I've alluded to, you know, we've got a unique profile. That profile can be shifted depending upon what we're eating. The low fiber then is causing a reduction in the production of these short chain fatty acids. And again, you may have heard of some of these. Acetate then, if you go to the chipper, the vinegar that they put on your chips is acetic acid. I'm not about to suggest that you run out and base your diet on fish and chips from the chipper, but acetate is acetic acid, butyrate and butyric acid and propionate. So these are quite smelly, they're not pleasant things to add to your diet. Well, obviously we all kind of like vinegar, but the precursor to these then is the soluble fibers. And again, the inulins, the pectins, the glucans that are in our fruit and veggies. In terms of the terminology then that you might be seeing on the web, the prebiotics are the fuel. So it's the fuel that our bacteria break down. The probiotics are the bacteria themselves. And again, you'll see articles suggesting that you take probiotics to improve your gut health. There's a bit of controversy there. A lot of people believe that taking orally probiotics, they won't actually make it to the colon where they need to be, where they need to live and reseed these populations. But again, there's clearly some benefits there. And then the postbiotics, and I think this is where science is moving a little bit at the moment, is the idea that, well, maybe we can bypass the diet and we can bypass the bugs, and maybe we can give people the beneficial molecules, and there's interest in the pharmacology of these molecules. So just the last couple of minutes, and just to put that in the context of disease, and this is a very challenging area really, because as I've alluded to, there's millions of different bacteria. They're very, very hard to study. And of course, we're all different in very, very different environments. But if you look at relatively large patient cohorts, and again, you can just see a couple of studies on the screen here then, in large cohorts in the US and in Sweden, so up to 110,000 patients, 45,000 patients, we see that there's a significantly lower risk of COPD in patients that have a high fiber diet. What was interesting to me here is that the benefit was linked to cereal fibers. In the second study, we see the benefit was linked to cereal fiber was greater than fruit fiber was greater than veg. And similarly, in the third study down here, again, we see that the benefit is linked to whole grain cereals. But not all fibers are created equally. And again, apologies, I'll whiz through this. It's tiny to see, but this is a study that was done in a healthy population. So again, a large population of healthy volunteers studied over time, and it showed that individuals that had a high fiber diet, and that's the column that's listed towards the right, showed improved lung function. And again, we need huge populations to see this, because obviously there's confounders. It could be a coincidence that people that eat fruit and veg go running a lot. So you need large numbers of volunteers to see this type of effect. And independent of all the other variables, it seems that a high fiber diet, we have improved lung function compared to people that eat a low fiber diet. If we go to animal models of disease, and again, the reason for showing you this is, of course, that we don't yet have evidence from patients with pulmonary fibrosis that diet has an impact, or modifying the microbiota has an impact. But we know there's an association between diet and lung function. And in the animal models, we can show that if you feed animals, for example, the postbiotic, the acetate, we reduce inflammation and get reduced viral problems. It's a nasty topic, but fecal microbial transplant. So as you would understand it, if you transfer healthy, happy microbes to a mouse from an animal that's been at a high fiber diet, you can reduce emphysema in models of emphysema in animals. And then the third example here, and this is the one that got me interested in this whole area, is that if you feed mice a low fiber diet, they're much more susceptible to asthma. You can cure that with a high fiber diet, or you can give the mice the propionate and cure asthma. Of course, these are animal models. It's very difficult to translate these to humans, but it's very compelling evidence that manipulating either the diet, the actual bacteria, or the metabolites can help improve respiratory disease. The final couple of papers I'll show then are just to give the balance to that. Not only do we think that fiber and short chain fatty acids are good, but there's evidence that if you feed animals a high fat diet, you can increase lung injuries. So again, these are models of acute lung injury and fibrosis. And a high-fat diet makes the injury worse because you get the exaggerated inflammation. So we're quite excited with the idea that diet and short-chain fatty acids can most definitely affect the inflammatory phase of the injury. And again, with support from ILFA, we're working on fibroblast responses. And again, I didn't show you any of the data. It's very preliminary, but we believe these short-chain fatty acids that are produced in the gut can modify the behavior of fibroblasts and reduce their ability to make scars. So our proposal is that if we can get the balance right between sort of fruit and veg components, and maybe we can reduce the high fat contents, we can definitely reduce the inflammation and potentially help prevent or reduce the fibrotic responses. I'll just leave you with that one analogy then. So I think we're all hearing about biodiversity in the wild and rewilding in our gardens and forests. But I think the same then applies to us and our microbiota, that if we want to look after the microbiota and help it produce these healthy molecules, we need to look after our diets and increase the fiber. If we're not great fans of fruit and vegetables, then there's ways we can do it, maybe by taking the inulins or the pectins or the glucans, and potentially coming down the lines, if we understand more about these metabolites, we might learn how to take the metabolites to help with the disease process. That's me. Thank you very much for your attention. And again, I'll try my best to answer any questions.
Thank you so much.
Thanks, John. There's two questions then we'll try and get through. One of them here, does using mouthwash have a negative impact on the oral microbe?
Yeah, I think it does. What's very unclear. So again, I skipped over the whole lung microbiome because it's quite a controversial field. So we know for certain that the lung is colonized with bacteria. In terms of profile, they're very, very similar to those that are within the oral mucosa. So what we believe is that just by aspirating little bits of saliva, we're colonizing the lungs with bacteria that would normally be in the oral cavity. What's very unclear is what those microbes contribute in the lung. I know there are studies in patients with fibrosis showing that the composition of the lung microbiota is different between a patient and a healthy control. And there's animal work showing that if you put you can identify bacteria that will exacerbate an inflammatory injury, and you can inoculate an animal and you can exaggerate lung injury. What's very, very unclear in humans is exactly what the lung microbiota is contributing. So the short answer was yes, mouthwash will affect the oral profile, but it's unclear what effect that has on the lung.
That's great, John. Just one very quick question. I had to just double check this on Google because I'm not sure, is this a spelling mistake? Does Fibogel help gut health? Have you heard of Fibogel?
Yeah, I've heard of Fibogel. So again, this is one of those things where in terms of gut health, a lot of the supplements are there to help with stool motility, soften the stool, and they would be more of the insoluble fibers that are basically trapping water and softening the stool. That definitely does have an impact on the environment that all of these bacteria live in. So that does affect the bacterial composition, but it's the soluble fibers that the predominantly of interest in this story for the breakdown and the production of energy in these metabolites. But yeah, Fibogel will affect gut health, and there's a strong case for it helping maintain gut health.
One final question, and then we'll throw over to Sean. Is there any role for supplements to protect lung health?
I can't really answer that. My strong hunch is yes. All the animal model data would show that high fiber diets or supplementing with the prebiotics, the inulins, the pectins, can protect the lungs. Obviously, these animal models are completely different to a patient lung because in an animal model, you often feed the animal with a nutrient before you injure them. And you see a beneficial effect because you're reducing the severity of the injury. Clearly, in many of the patients, the disease has been progressing for a long time, and it's a different phase. So it's hard to produce any data to show this, but I think if you know, again, if you go back to Prof. Hurley's talk, you know, patients with sort of relapsing and episodes of inflammation, then I think there's a strong argument for doing as much as we can to maintain the gut health. And worst case scenario, we're eating more fruit and veg. You know, I think it's fair to say it definitely do no harm.
Great, thanks a million, John. Over to you, Eddie.
Thank you. And our next speaker, who has waited very patiently, is Sean O'Shea from Kerry. Sean moved to Ireland, to the Dingle Peninsula 4 years ago, and after retiring as a business analyst in the IT industry. We are delighted to extend a warm welcome to Sean and look forward to hearing his perspectives on living with pulmonary fibrosis. So Sean, I'll let you have it now. Thank you.
Yeah, thank you, Eddie. And thanks to Gemma for inviting me to take part in this talk. Anyway, prior to moving to Ireland, I was quite a fit person. I used to play badminton twice a week, and I was a regular ballroom dancer. So I was quite fit, I thought. I moved to Dingle, the Dingle Peninsula, and I was out walking every day in this beautiful place around here. I loved it. I had a great time. And after about a year and a half, I noticed that I was getting breathless walking up steep hills. And I just assumed that I was getting old and unfit because I wasn't doing all these activities I'd been doing. Anyway, at one point, I had gone to a GP because I was having problems with gastric reflux at night. And he put me on to proton pump inhibitors, pantoprazole, and that helped address that. Very good. But while I was there, he also asked if there were any other problems, and I did mention that I was breathless. So next thing was he examined my chest. Within 24 hours, I was in Tralee getting an X-ray of my chest. Results indicated fibrotic changes in both lungs. He then sent me up for a CT scan in Tralee, and the results returned as possible COPD with moderate fibrotic changes. So, you know, I thought, oh, well, that's better than having pulmonary fibrosis. Then he referred me to Cork University Hospital, and I joined Dr. Henry's Respiratory place, his clinic. And after he gave me a very good examination, looked at all the results, and he said, no, I think this is more like pulmonary fibrosis. So he decided to do a bronchoscopy and a lung biopsy, and I had those, but the results suggested features not in keeping with classic IPF. And he thought that I might have a likely eosinophilic pneumonia or even a connective tissue disease coming up. So he put me onto a high dosage of steroid, and we went forward with that. Anyway, later appointments came up with Cork, and he really went into the history of my past and also what my current history was like. And we realised that I was living in a very damp house in Ballyferriter. There was mold on the walls, and he suddenly changed the diagnosis to fungal hypersensitivity. So I was then put on to antifungal treatment. That went on for 6 months, but my breathlessness was getting worse. I was getting dry cough, and I was generally deteriorating more. So this time I had a CT high resolution thorax with IV contrast. And within 2 weeks of that, he rang me up and he said, I'm putting you on antifibrotic, nintedanib. He said, it looks like definitely you've got IPF. So that was, I finally got a diagnosis, which I thought that rang true with me, and rang true with him. So at that point, I joined ILFA, you know, because I now got IPF, and I got a tremendous welcome from Gemma. And the first thing we did was I got invited onto a respiratory rehab course run by Limerick, Gordon Cagney. And I've been doing that now for the last year and a half, almost every week. So I think that's proving very good for me. But as well, ILFA also gave me other opportunities, of course. The World Cafe, I had access to the EU IPFF conferences, patient information days like this one, I've taken part in online Let's Talk sessions. I've joined the 12-week sing-song course. And I also was on a 12-week respiratory course by Limerick University Physiotherapy students, which and I also got a dietary consultation. So ILFA has been really good for me. You know, apart from feeling incredibly supported by ILFA and the fellow IPF patients, I've gained some really good knowledge about this disease process, especially within, you know, with sessions like this one on today. I've had access to latest IPF research, respiratory self-care I'm learning about. I'm understanding about palliative care aspects, the complexity of diagnosing the differences between the different IPF and other ILD diseases, and awareness of the stress that's caused to carers of IPF patients. As well, and most of all, well, not most of all, but for me, I have a rewarding feeling that I'm not alone in this disease. And there's other people around there, and we can talk with each other. And I get a lot of knowledge from them individually. CUH have also been giving me some continuing support, because Professor Hurley mentioned care pathways earlier on. And I've been getting regular phone calls from the respiratory nurse in CUH. And also just recently I've taken on a spirometer and an oximeter, and I'm giving weekly readings, which are transmitted on the internet. So they're monitoring me as I'm going along. I'm also doing a regular 6-minute walks in my own house. So I'm monitoring that to see how I'm progressing or deteriorating as appropriate. So finally, I want to thank all people associated with ILFA. I think ILFA have made a very big difference to my life. Because there's no cure for IPF, I know at least I'm getting support in other areas, and it helps me, not just physically, but also mentally. I'm getting a lot of benefit from this. And of course, I've got the ever helpful Gemma, who's really tremendous. She's always there every week, and she gives stuff. And I'd also like to give a mention to Gordon Cagney and to Petra Grian for the excellent pulmonary rehabilitation course that I've been taking part in. Anyway, that's me.
Thank you, Sean. Thank you for your really kind remarks, and hopefully we'll continue to shine in the future. Thanks again. So I'll move on now to the finale. Now that we're approaching the end of the event, I would like to offer my sincere thanks to all our speakers for their time and their professional expertise. I think it was a great series of talks today. ILFA is honoured to have great clinicians available to participate in our events, and we really do appreciate all that they do for us. We really, really do. I would like to extend thanks to Gemma for all her work and dedication with organising the event, and a really, really special thanks to Justin from myself and everybody here with regard to the expertise and managing this online event. I also wish to acknowledge the work my fellow committee members who dedicate their free time, talents to run ILFA so diligently. I am enormously grateful to them for all their hard work and total commitment. Fundraisers, they deserve a special mention, as ILFA's work would not be possible without their efforts. ILFA is greatly dependent on donations to function, and all support is greatly appreciated. If you would like to fundraise for ILFA, please get in touch. If you or a family member are a member of a club, a society, a company, please consider ILFA as a potential charity partner. We would welcome any such opportunity. I never miss a chance of making the old advertisement. We hope you enjoyed the Patient Information Day and will join us for our next one. I would like to express my thanks again to the HSE and the National Lottery funding for supporting this event. Thank you all again. I hope you enjoyed the day, and I'm wishing you a lovely weekend. Stay safe. Agus Slán. Take care.